Buddy, Dr. Rafich here from Vettriage. We are on the very last publication for this November 2024 Veterinary Surgery Journal. This is laparoscopic ultrasound-guided microwave ablation of hepatocellular carcinoma in a dog. This study comes out of University of Florida, and I'm not a fan of this one. I think that it's an overly complex methodology to treat something when surgery probably is just better, but better and less follow-up needed and all that, and kind of more proven track record. But in any case, we do need newer procedures that are minimally invasive or less invasive, so it's still important to know, but I'm not a big fan of this one, but you'll be the judge. Objective is the aim of the study is to describe laparoscopic ultrasound to guide microwave ablation of hepatocellular carcinoma in a dog. This is a 13-year-old female spayed husky. The caudate lobe cancer measured 2.7 centimeters by 1.9 centimeters by 2.3 centimeters. Laparoscopic ultrasound was used to guide percutaneous placement of the microwave ablation probe in the mass. Then ultrasound was used laparoscopically to define the tumor margins for the placement of the probe within the medial and lateral aspects as well as the center of the mass. That ultrasound allowed visualizations of vessels so they could be avoided. The results found safe ablation was accomplished, no complications. Follow-up CT scan, 3 and 12 months, showed complete ablation of the caudate lobe mass, but there was a progressive increase in size of the right medial lobe mass. The right medial liver lobectomy was performed 13 months after the microwaving, and that confirmed also cancer. A dog was euthanized 777 days after microwave and 1,445 days after the initial left lateral lobectomy for hepatocellular carcinoma. Conclusion was that the laparoscopic ultrasound was useful in guiding complete and safe microwave ablation of liver cancer in a dog. All right, hepatocellular carcinoma is the most common primary liver neoplasm in dogs. Massive hepatocellular carcinoma is the most common type. However, there's also nodular and diffuse. Surgical resection versus partial or complete liver lobectomy is treatment of choice for solitary massive lesions with reported median survival times exceeding 1,460 days. However, surgical resection may not be feasible for nodular and diffuse forms. Loco-regional therapies like microwave ablation can be considered. Microwave ablation involves use of an electromagnetic field to create a rapid and homogeneous heating of tissue, causing coagulative necrosis of the tumor. People have also used the CUSA machine, which is the cavitronic ultrasonic and suction apparatus, something like that, or aspirator, something like that. And then it's a similar idea in that it is a probe and it creates these waves that vaporizes cells that have high water volume, and liver is one of those cells. At the same time that it's doing that, it's also suctioning the tissue. So to me, microwave ablation is another example, same kind of theory as the CUSA. In people, microwave ablation of liver tumors is performed laparoscopically with laparoscopic ultrasound, allows concurrent staging, and ensures safe and complete ablation of tumors. In dogs, microwave ablation of liver lesions is rarely reported and has been performed with laparotomy, laparoscopy, and percutaneously with ultrasound guidance. Laparoscopic ultrasound of the liver in dogs has more recently been investigated and shown to be feasible for access to all liver lobes via a single incision. So for this case, the CT scan of thorax, abdomen, and pelvis 3 months prior showed multiple variably sized lesions in the caudate, right medial, and left lateral lobe. The largest mass was the caudate one at 2.7 centimeters by 1.9 centimeters by 2.3 centimeters, hypoattenuating and contrast enhancing. This is it here. You can see the arrowhead. So look at that. You see the arrowhead. Shows the transverse pre and post contrast as well as dorsal and sagittal images with the arrowhead showing the mass. So surgical options included caudate lobectomy versus microwave ablation of the caudate lobe. The dog was in dorsal recumbency, 30-degree reverse Trendelenburg on a hydraulic float table, 30 millimeter laparoscopic surgery port. The abdomen was insufflated with carbon dioxide, pressure of 8 millimeters of mercury, and a 5 millimeter 30-degree laparoscope with high definition camera. 10 millimeter diameter, 13-5 megahertz curved array laparoscopic 4-way transducer was used within a 15 millimeter cannula into a single incision for laparoscopic surgery. A 17 gauge microwave ablation probe is used, inserted percutaneously through the right cranial abdomen with laparoscopic visualization. The probe was inserted into the lesion. Laparoscopic ultrasound was used to visualize the parenchyma to ensure correct placement. The lateral margin of the mass was ablated for 5 minutes at 30 watts and 3 minutes at 45 watts at separate locations. The medial margin ablated for 3 minutes at 45 watts, 2 minutes at 35 watts, separate locations. Center of the mass ablated for 5 minutes at 65 watts. And then I'm going to show you, the images up there. So over here, these two, A and B. A is showing the before microwave ablation with color Doppler signal appreciated within the caudate lobe mass indicating perfusion. And then for B, after microwave ablation, the mass now is necrotic, heterogeneous, cavitation. You can't see any color Doppler signal, suggesting complete coagulative necrosis. And the bottom two pictures, A is a laparoscopic ultrasound transducer, and then for B, there's the actual images. And then in the pictures over here, the CT scan right here, it's showing here the arrowheads and showing that the tumor is slowly shrinking over time. And so that's the ID here, 3 months and 6 months and 12 months afterwards. So the results found the dog did pretty well. There were other nodules that were tested in other liver lobes that were deemed benign at the time, but then they grew over time, which then developed into further cancer, and then they removed them. Okay. The dog was finally euthanized due to declining quality of life, and this is 777 days after microwave and 1,445 days after initial left lateral lobectomy. Discussion. The European Association for the Study of Liver Guidelines states that the thermal ablation is recommended for patients with a single hepatocellular carcinoma nodule or 2 to 3 nodules that are less than 3 centimeters that are not amenable to surgical resection or liver transplantation, as microwave ablation of tumors over 3 centimeters results in incomplete ablation. However, microwave ablation has been successfully used to treat cancer tumors as large as 8 centimeters for palliative rather than curative intent. Complete ablation following microwave in people ranges from 86.7% to 97%, or 95% rather. And there was a study that showed no difference in survival time and disease-free interval for hepatocellular carcinoma less than 3 centimeters treated with microwave ablation versus surgical resection. To reduce morbidity and have minimally invasive techniques for microwave in people include laparoscopic microwave ablation and percutaneous image-guided techniques using modalities like ultrasound, CT, or MRI. However, a limitation of laparoscopic surgery is a lack of tactile feedback, so you can't assess oncologic margins, which could mean incomplete ablation, so you use an ultrasound to help you with that. In people, a prior study comparing open laparoscopic and percutaneous microwave ablation of liver tumors revealed a higher rate of local recurrence in tumors treated percutaneously. However, increased patient morbidity and complications have been previously reported with laparoscopic approach, indicating a drawback of this technique. Most of these complications were linked to carbon dioxide. Therefore, the use of a lift laparoscopy instead of insufflation for laparoscopic microwave may be a consideration. Findings on CT scan consistent with complete thermal ablation in people include hypoattenuation of the entire volume of the tumor, indicating necrosis. Lack of significant hypoattenuation or hypoattenuation does not extend the entire tumor volume indicates incomplete ablation. A thin peripheral rim of contrast enhancement might be seen initially due to post-ablation inflammation or fibrosis and does not necessarily indicate incomplete ablation. This rim should resolve over time. In people, increased accumulation of copper has been detected in tissue samples of hepatocellular carcinoma. Patients with Wilson's disease, which is a genetic mutation causing altered copper metabolism and increased copper in liver, have been reported to be higher with hepatocellular carcinoma, or have been reported to have a higher incidence of hepatocellular carcinoma. Interestingly, a prior report in dogs showed that hepatocellular carcinoma lesions tend to have a lower copper concentration than non-neoplastic liver tissue. So that's it. It's a good study overall for exposure. I'm not sold on the concept, I guess, because when you look at how peripheral this tumor is on the liver lobe, for a surgeon, that's quick to remove that. it doesn't really require all these monitoring and all that stuff too. And then while you're in there, you can biopsy the other liver lobes instead of doing aspirates of them. And you can, of course, do a full abdominal exploratory as well. So I'm just not a fan of this type of stuff, but I do like that we continue to try new things. We have to, especially for clients that want this type of stuff, because it is less invasive, of course, than full-on surgery. So, but then again, how invasive are we talking when we have to do CT scans afterwards to look at, to monitor these patients? CT scan requires sedation or anesthesia. Could be only a few minutes, but still, that's repeated episodes versus one surgery and then just follow up with ultrasound thereafter. So it's just a bizarre thing to consider, but it is an option. All right, everybody, thanks so much. We're going to move on to another journal and keep on going. Take care.